Chairs, dear ladies and gentlemen, I'm talking now about blood pressure control and anticoagulation in hypertensives with atrial fibrillation, two important sides of the same coin. Stroke, by far the most important complication that is affected by elevated systolic blood pressure, is highlighted always and again also in the global burden of disease studies published here in the Lancet in 2016. And no matter where you go globally or any country in the world that has been analyzed, high systolic blood pressure is the major risk factor, the number one first for stroke. If we compare the risk associated with stroke with other risk factors such as current smoking, we see that hypertension increases the risk, the odds ratio for stroke, but also smoking. If you look into all strokes and also ischemic strokes, but we should not dismiss the importance, particularly for intracerebral hemorrhage. So hemorrhagic stroke, you see there is no significant effect associated with smoking, but the higher impact on hypertension is clearly shown here. And again, summarizing that hypertension, elevated systolic blood pressure, is the most important factor for both ischemic and hemorrhagic strokes. And clearly this is also now linked to my presentation in patients with atrial fibrillation and anticoagulation. We stratify the patients with regard to stroke risk and the indication to anticoagulate the patients with the CHED-SWAS score, but we have also the Has-Bled bleeding score, which has very often been criticized because similar factors, as an overlap between the risk factors leading to bleeding risk in the Has-Bled score, but also to the increased stroke risk, one of which is actually stroke itself, which gains 2 points in the CHED-SWAS score and is also a risk factor for bleeding. We know that patients with a previous stroke are at high risk for bleeding. But clearly hypertension is again also a risk factor for stroke in the CHED-SWAS score, but also for bleeding. And as it has been developed in the Has-Bled score, elevated systolic blood pressure over 160 millimeter mercury. The most important point with regard to the Has-Bled score, I think, also for my personal clinical practice, is that we can use it as a reminder that the Has-Bled score contains very important modifiable risk factors, among which hypertension is so important because we can lower blood pressure and thereby decrease the bleeding risk, particularly for hemorrhagic stroke, particularly during anticoagulation. Other modifier risk factors are drugs and alcohol. Drugs, meaning here antithrombotic drugs, antiplatelet drugs, and NSAIDs are the very important drugs that we should try to avoid as much as possible in these patients, also moderate alcohol intake. So the CHED-SWAS score, again, I mentioned already, contains also hypertension as a risk factor with a single point. And that brings us already to the consideration that we can already start to think about to anticoagulate all patients that are hypertensive with a diagnosis of hypertension because they have at least 1 point. And that is a situation where we may consider already anticoagulation, both in males and females, while in individuals with a CHED-SWAS score of 2 or greater than 2, we generally recommend, because of the net clinical benefit evaluation, anticoagulation in those subjects. So I like also the recent 2020 ESC guidelines that put forward the ABC pathway and highlighting also the management with the C of the comorbid conditions, which are very important in these patients because they affect the overall risk and the progression also for other complications such as heart failure, but also the risk for stroke and also bleeding, and hypertension is therefore very important. We should not forget to manage hypertension in patients with atrial fibrillation because the prevalence is so high, as you will see. A clear advantage of the NOACs, the non-oral vitamin K antagonists, non-vitamin K oral antagonists, NOACs or DOACs, is that they reduce the risk for intracranial hemorrhage and all-cause mortality, as shown in this meta-analysis of the pivotal phase 3 trial by Christian Ruff. And therefore, we should also add to this benefit that is brought about with the NOACs as compared to vitamin K antagonist warfarin. Also, we should take care of blood pressure control because it can also reduce the risk of intracranial hemorrhage. So clearly, also in our recent guidelines, but also in the European Society of Cardiology guidelines, there was a recommendation that preferred the use of NOACs based on this finding over the use of warfarin because of the benefit in terms of the reduction of intracranial hemorrhage risk. Clearly, and also antiplatelet monotherapy is not recommended for stroke prevention in AF patients, and in our guidelines also not recommended for primary prevention, with the exception of few special indications, while antiplatelet therapy is still used in secondary prevention in patients with a sinus rhythm as far as stroke prevention is concerned. Now, in these 4 landmark trials, this study looked into the frequency of the comorbid conditions, and you can see and appreciate that by far hypertension with 87.7% is by far the most frequent comorbid condition in those patients with atrial fibrillation. And this is clearly also associated with age because the prevalence of hypertension in the elderly is very high, and the prevalence of atrial fibrillation in the elderly is high and increasing based on recent data. And in our country, in Germany, we did a study in the octogenarians there where we have a prevalence of atrial fibrillation of 10% and increasing up to 20% if the octogenarians further age and get older. Was also a surprise, as put forward by Athanasios Manolis and colleagues, including Professor Mancha, that at the very beginning, when you looked into the studies, everybody was focusing on the novel oral anticoagulants at that time and were excited about these new developments that the blood pressure control and management of arterial hypertension seemed to not appropriately appreciated in these studies. As these authors quoted, blood pressure remains remarkably unappreciated in previous and recent atrial fibrillation trials. Very limited if any data are provided regarding blood pressure, including in-study and final blood pressure levels, blood pressure control, and concomitant antihypertensive medications. There are only a few studied then later on as post-hoc studies that reported blood pressure, and it seems that blood pressure monitoring was also very limited in some of these studies, and it's also related to the problems of blood pressure measurement. But nevertheless, in one of the studies, such as the Aristotle study, where the apixaban was compared with warfarin, including more than 18,000 patients, again here, 87.5% had a history of hypertension, and at baseline, almost a half, 42% of the patients were not controlled based on the blood pressure values that were determined at baseline. And what the authors did in this post-hoc analysis, they looked into the follow-up during the course of the study and defined those patients with uncontrolled hypertension during the course of the study that had at least 2 measures during follow-up that were above the hypertension of cutoff values of 140 systolic and 90 millimeter mercury diastolic. And what you can see is that on the those patients on the right-hand side in the forest plot with uncontrolled blood pressures had a higher risk for stroke overall, but particularly a higher risk for hemorrhagic stroke, and also numerically higher risk for bleeding and a significantly higher risk for any bleeding and the combination of a major or clinically relevant non-major bleeding. So again, uncontrolled hypertension increases the risk of stroke, also in patients anticoagulated in this trial, and particularly hemorrhagic stroke, but also overall bleeding risk. So what do our guidelines recommend? First of all, that when we start oral anticoagulation, and goes along also with the Hess blood risk factor, systolic blood pressure above 160 millimeter mercury, we should not start in patients with, we should not start with anticoagulation when the systolic blood pressure is above 180 millimeter mercury and diastolic blood pressure 100 or over. And the main target should be blood pressure in the normotensive range, below 140 millimeter mercury, and even lower if possible. However, this is a 2A recommendation, so that should be done with a level of evidence B, and that indicates already that there is still a need for further studies to increase the strength of recommendation towards a recommendation class 1 would be ideal, and the level A at least, B at least, but 1B we would be already happy if we have a stronger class of recommendation available. One problem with the lack of data, I think, is the issue of blood pressure measurement, as highlighted in this slide by the chair of our working group of blood pressure measurement of the European Society of Hypertension, George Steju, because as we all know, there's a large beat-to-beat intra-atrial blood pressure variation in patients with atrial fibrillation, as shown on the right-hand side, when you compare it with patients in sinus rhythm. Nevertheless, as also been mentioned and emphasized by the experts such as George Steju and colleagues, it's if we do a proper blood pressure measurement, it's actually not too bad. What is recommended to do, at least in patients with atrial fibrillation, triplicate measurement on each occasion. And the evidence from validation studies for using automated electronic blood pressure monitors is still limited. And we need more studies and more devices, validated devices. But nevertheless, they show reasonable accuracy, particularly in measuring systolic blood pressure, with a small overestimation of diastolic blood pressure. So basically, we have modern oscillometric automatic devices available that can also measure blood pressure properly for clinical use and management in patients with atrial fibrillation. ABPM is also feasible in stable AF patients with a similar proportion of errors as in individuals without atrial fibrillation. But I think proper office blood pressure measurement and even home blood pressure measurement with automatic electronic devices and doing triplicate measurements, I think, is a very important recommendation for monitoring. So now coming back to the drug treatment approach and the current guidelines for uncomplicated hypertension. You are all very well aware of the core drug treatment algorithm that is recommended in our European guidelines. However, this will be changed when we talk about atrial fibrillations, because the beta blockers, which are highlighted here in the yellow box, can be used at any step, and they will move forward to the first line therapy because we regularly use them and need them for heart rate control in patients with atrial fibrillation. And also oral anticoagulation should be added, as we know and discussed already in the previous slides. The alternative for beta blockers might be non-DHP calcium channel blocker, namely verapamil or diltiazem for heart rate control, because of other conditions, comorbidities, or the patient might have, or also based on tolerability or anticipated adverse effects in patients that would be treated with beta blockers. When we talk now about blood pressure control, we might use already 3 drugs, and then we have an anticoagulant. We have already 4 drugs, and then we have some other comorbid conditions like diabetes, coronary artery disease using a statin, etc. So we pretty early end up to use polypharmacy in these patients. That means use more than 5 drugs. And this study, in one of the pivotal phase 3 trial with the NOAC, the ROCKET-AF trial, in which rivaroxaban was compared with warfarin, looked into the association of polypharmacy with outcome in the trial. And what the investigators found when they defined polypharmacy as a common definition as those patients that took at least 5 drugs, and multipharmacy, those patients that used actually 10 or more drugs as shown in the red columns, and compared it to those without polypharmacy, so taking a maximum of 4 drugs, you can see that here's the hazard ratio indicated on the y-axis. There is no significant effect on thromboembolic events, stroke or systemic embolism, while those patients in blue with polypharmacy and those patients in red with multipharmacy showed a significant increase in events for major bleeding, fatal bleeding, and also mortality. And this is the combined analysis for both patients that were randomized to either warfarin or rivaroxaban. So independently from the oral anticoagulation, there was a significant increase in bleeding risk and mortality in those patients with polypharmacy. Obviously, there's the question of the chicken and egg question. What comes first here? Because you may argue that those patients with polypharmacy have more comorbid conditions and therefore are at higher risk, but also drug interactions might play a role that increase also bleeding risk and thereby also maybe fatal bleeding and also mortality. And this is important to acknowledge that all oral anticoagulants, warfarin, as we all know, vitamin K antagonists, but also the NOACs show a potential for drug interactions, and also the NOACs are all eliminated to a certain degree by the kidney. So it's very important to monitor kidney function, to adjust the dose to kidney function, and also to check for potential drug interactions. You may look it up, and there's a recent update on this paper now published just last week based on the European Heart and Rhythm Association document summarizing all these aspects. I have no time to go into the detail because I would just want to focus on blood pressure control and antihypertensive treatment. And I have good news for us here summarized in this slide. Now, when we look into the blood pressure lowering drugs we use for blood pressure management in clinical practice, as recommended in our guidelines, the major blood classes I highlight in green color do not show significant drug-drug pharmacokinetic drug interactions with the NOACs. That means they do not affect the plasma concentrations when they are used concomitantly and thereby do not affect the bleeding risk. And that applies also to the DHP, the most important DHP calcium channel blocker, amlodipine. However, the alternatives to beta blockers for heart rate lowering, which are the non-DHP calcium channel blockers, verapamil or diltiazem, are different from amlodipine because they show significant drug interactions with many other drugs, but also the NOACs and also warfarin actually. This is a study that actually, again, in the ROCKET-AF trial, just looked into those patients that were treated instead of a beta blocker for heart rate lowering, potentially with a non-DHP calcium channel blocker, and found no significant effect between rivaroxaban users or warfarin users that use this. So when they combined the both treatment groups, both rivaroxaban and warfarin, and looked into the outcome in this trial, they found again no significant effect for thromboembolic events, but they found a significant increased risk for bleeding events, and again in those patients that used the non-DHP calcium channel blocker. Major bleeding, 1.5 hazard ratio, and intracranial hemorrhage, almost a threefold significantly increased risk for intracranial hemorrhage. So these drugs, verapamil and diltiazem, might increase the bleeding risk, and because potentially also increase the plasma concentrations of both rivaroxaban and also of warfarin. They may also indicate some disease comorbidity situations in those patients that use this type of drugs that may also affect the bleeding risk, which is a confounding factor that has not been solved. But as shown in this slide, another study supporting again the idea that the diltiazem and verapamil, as other drugs, amiodarone and also erythromycin, that we know that both have drug interactions with the NOACs, increase the bleeding risk. In this single center study from the United States, where you can see during follow-up for 1400 days, you see the Kaplan-Meier curves for bleeding events, and you see those patients that were treated with a DOAC, but without other drugs that cause drug interactions with the DOAC, had a significantly lower bleeding risk as those patients compared that had a potential for dual drug interactions, because their patients were treated with diltiazem, verapamil, or some of the other drugs that I mentioned here. So in summary, the non-DHP calcium channel blocker are the only drugs among our first-line blood pressure lowering drugs that show potential for drug interactions when we anticoagulate patients, both with warfarin but also with the NOACs. The mechanisms I just would like to summarize here in a short summary in this slide is that there are two proteins that affect the plasma concentration of all four NOACs. One is the PGP, P-glycoprotein, which is an efflux pump leading to the excretion of the NOACs, and this protein affects all four NOACs. And the most important cytochrome P50 enzyme 3A4 affects only apixaban and rivaroxaban, but not dabigatran and edoxaban. And therefore, verapamil, which is an inhibitor, diltiazem the same, of both proteins, they will lead to an increase in plasma exposure for the NOACs, particularly for apixaban and rivaroxaban, potentially thereby increase the bleeding risk. So, in summary, again, good news in green. Blood pressure control is very important. Antihypertensive treatment is important to reduce the stroke risk in our patients, also with atrial fibrillation, increase the bleeding risk. We can do this with the first-line blood pressure lowering drug and also with spironolactone in patients with resistant hypertension, for instance, because they do not show significant interactions, pharmacokinetic interactions. The only drug class among our armamentarium that would affect the pharmacokinetics and also the bleeding risk in patients during anticoagulation with the NOACs particularly are the non-DHP calcium channel blockers. So in summary, the goals in hypertensive patients with atrial fibrillation are clearly rhythm control. Sometimes we can achieve this now even with using modern therapies, ablation, interventional treatments, but more often we need heart rate control. Beta blockers are the preferred drugs for this. The non-DHP calcium channel blockers are more problematic because of the pharmacological interactions I have discussed. The prevention and treatment of heart failure is actually a major, in addition to stroke prevention, a major target aim in these patients because it seems to be affect significantly outcome or prognosis in these patients. Stroke prevention with oral anticoagulation is very important, and blood pressure control is also very important, even though I must admit that we still lack solid data and we need more data, and the optimal targets during anticoagulation in patients with atrial fibrillation are not yet established. So that's a gap, a knowledge gap we have to address in future research. But nevertheless, blood pressure control protects against both ischemic and hemorrhagic stroke, which is very well established, and this applies also to patients with atrial fibrillation, particularly in anticoagulated patients. So we should not dismiss this important goal in the management of patients with atrial fibrillation. So again, as a reminder, when we overall look into the management of these patients, looking to the Hess-Blood score, we are reminded by the H in the Hess-Blood score. So the first letter, first comes first, you know, hypertension control is very important, but also the modifiable other factors are the drugs, and the most difficult drugs and high-risk drugs are the NSAIDs, particularly in the elderly, particularly with the bleeding history. They should be avoided because there are several mechanisms increase the risk for bleeding in these patients. And antiplatelet drugs should be also omitted as much as possible when the patients are beyond the acute coronary syndrome after intervention and standing in consulting with the cardiologist in these patients, and that should be individualized. So blood pressure control and anticoagulation is very important. We can do that. Antihypertensive combination therapy plus anticoagulation is essential for safety and stroke prevention. And the only drug classes we should, sometimes we have to use because patients do not tolerate beta blockers, but we should acknowledge that when we use them, that they might increase the bleeding risk, as I have discussed. And then it's even more important that we modify all other factors that would contribute to an increased bleeding risk. With this, I would like to thank you again for your attention, and I'm happy to discuss any questions you may have.
In these lectures, يعني في 3 important points. Number 1, NOACs is more safer than warfarin. Number 2, we must start NOACs when the blood pressure below 114 and 90. Number 3, this is the most important point, non-dihydropyridine interact with NOACs. So when we take the verapamil or diltiazem with rivaroxaban or apixaban, we must take in our consideration this point. Nothing.
لو سمحت، كان الام دي بالنسبه للفاكسين بتاع الكوفيد يعني في رير كومبليكيشن منه اللي هو الثرومبوزس، التجلطات او الثرومبوسيتوبينيا. فكتير من الناس بيسالونا صحيح هي رير، ولكن كتير من الناس اللي بياخدوا حتى احنا اللي بناخد التطعيم، هل ناخد مثلا اي حاجه انتي ثرومبوتيك او انتي بليتلس معاه؟ بعض الدكاتره كتير جدا اعرفهم بياخدوا اسبرين. الاسبرين فيه مشكله لان العيان ده ممكن يحصل له ثرومبوسيتوبينيا، والاسبرين بيعمل الريفرسبل انتي بليتلت اجريجيشن، فبالتالي لو هيحصل بليدنج هيحصل بليدنج اكتر ومش هيحمي من الثرومبوسس. فهل من العقل معقول ان احنا اي حد ياخد تطعيم نديله النواكس؟ ده سؤال يعني، وخصوصا ان النواكس دخل في البروتوكول بتاع علاج الكوفيد، فبالتالي لو احنا خايفين برضو من الثرومبوزس فمن الافضل ندي النواكس عن الاسبرين. ده رايي يعني. الحاجه الثانيه ان كتر التحليلات بتخلينا نفكر في حاجه جديده. يعني قبل الكوفيد كنا بنعمل الدي دايمر لما نشك في عيان عنده يا اما دي بي تي يا اما بالمونري امبوليزم او حاجه زي كده. دلوقتي اصبح كل الدكاتره اللي بيجوا لهم عيان سخن بيعمل دي دايمر، فالدي دايمر بيطلع عالي ممكن بالالافات. فبيجي مريض عنده دي دايمر عالي، بنعمل له كل التحليلات الكوفيد ما نلاقيش عنده كوفيد خالص، بنشوف الرايت فنتركل ما فيش عنده دي بي تي، ما فيش عنده بالمونري امبوليزم. فلما تخش بقى احنا كل يعني طول عمرنا بنربط الدي دايمر بالبالمونري امبوليزم وكده، فلما تخش على النت تشوف هتلاقي دي دايمر بيعلى جدا جدا. اول حاجه روماتويد ارثرايتس، تاني حاجه الالسراتيف كولايتس وحاجات كتيره جدا. فساعتها الواحد فعلا لما بسال العيان واخد هيستوري معاه الاقي فعلا عنده روماتويد. فهل انا ابقى ساعتها غلطان لو انا وقفت الدواكس او النواكس ولا لا؟
يعني بص حضرتك، انا هرد على حضرتك من منطلق يعني معلومات خاصه، لان طبعا انت عارف حضرتك موضوع الكوفيد ده موضوع جديد ولسه فيه كلام كتير. طبعا هو الكلام بتاع الثرومبوزس والحاجات دي اتقال في الفاكسين بتاع الاسترازينيكا، والحقيقه لما درسوا الموضوع لقوا ان الانسيدنس بتاعته هي الانسيدنس اقل من الانسيدنس العالميه اللي بتحصل للناس اللي بيجي لها ستروك. يعني قصدي مش بالانسيدنس اللي يخلينا نجارد اجينست الفاكسين وندي اسبرين او ندي نواكس. دي واحد. اتنين، حته ان احنا كدكاتره انا رايي تسببنا في بعض الكومبليكيشنز اللي حصلت للعيانين. الاجريسيف تريتمنت في الكوفيد وان احنا بندي للناس كلها ذا سيم لاين بدون ما نعمل كلاسيفيكيشن دخل الناس في مشاكل كتيره، ويمكن على راسها دلوقتي الميكروب بتاع الفانجل انفكشن الموجود ده، ما هو ده من الاوفر دوز بتاع الكورتيكوستيرويد اللي الناس بتاخدها بدون تحسب. حضرتك سواء الدي دايمر سواء الفريتين سواء ال دي اتش، دي مش دايجنوستيك تيستس، دي اختبارات او فحوصات بتاسس السيفيريتي او بتاسس السيفيريتي اوف باثولوجي، فلا اعتمد عليها ابدا في بدايه علاج. انا شخصيا بعمل كده. يعني العيان عنده كلينيكال بريزنتيشن وعنده ابدا اشوف الاختبارات دي اخبارها ماشيه ازاي. لو بوزيتيف يبقى كده انا بعمل انشورنس للدايجنوزس بتاعي، وابدا بقى اتكلم في الايه في الليفلز. تاني حاجه الدي دايمر عشان ابدا ادي للعيان حاجه نواكس او حاجه انتي كواجولانت او كذا. في دايمر يعني هو الطبيعي بتاعه 0.5، افرض لقيته مثلا 0.6، هل هتعامل معاه زي اللي عنده الدي دايمر 15 و20؟ فانا شايف ان الموضوع بقى فيه اجريسيف مانجمنت بعنف وبدون ما بنعمل جود كلاسيفيكيشن للكيسز بيفور وي بيجينينج ذا تريتمنت.
كلام حضرتك مهم جدا، وانا باختصار بنصح الساده الزملاء جوجل سيرش كوفيد 19 recent guidelines، هيلاقوا فيه كل التفاصيل، وهيلاقوا ان 99% من الحاجات اللي احنا بنعملها هنا ندي كورتيزون بكميات كبيره وندي انتي بليتلس وانتي كواجولانس، ده كلام فاضي وغلط، مفيش مبرر الا في حالات محدوده جدا اللي هي الهوسبيتالايز بيشنتس. وبالتالي انا انصح الزملاء، بس يعني ده سهل، جوجل سيرش كوفيد 19 recent guidelines، هلاقي فيها كل حاجه، ومفيش داعي ان احنا نقعد ندخل في متاهات ونفصل ادويه لها خطوره وممكن تعمل بليدنج وممكن تعمل سيريبرال هيموريج بدون داعي. وبعدين الدي دايمر زي ما حضرتك اشرت في 20 سبب بيزودوا الدي دايمر. فيعني انا شايف ان الامور زادت عن حدها، وان الدكاتره بتتخبط وبتكتب حاجات وبتالف بروتوكولات وملهاش اي لازمه.